Thank you for a nice introduction. For the next 90 minutes, I'd like to briefly introduce main results of host bleeding risk, RCT, where we try to pursue the optimal duration of DAPT after PCI according to bleeding risk. Here's my disclosure. High bleeding risk is a prognostic factor after PCI. Academic Research Consortium defined HBR several years ago. I participate in ARC. We proposed 12 factors to define HBR: age, renal disease, liver disease, active cancer, anemia, thrombocytopenia, and stroke ICH, bleeding diathesis, prior bleeding, history of transfusion, anticoagulant, NSAID, steroid, and planned surgery under DAPT. Of course, among them, there are minor criterion or major criteria depending on the severity of certain disease. Major, less than 11, major, above 11, minor, thrombocytopenia, major, stroke, within 1 year, major, bleeding diathesis, major, prior history of within 6 months, major, anticoagulant, major, NSAID, minor, and planned surgery on the DAPT, major. What's the meaning of HBR? That means the patient's risk of major bleeding is 4% or above within 1 year after PCI, or risk of ICH is 1% or above within 1 year after PCI. One major criterion meet this criteria, while minor criterion required 2. Thus, if you meet one major criterion, HBR is defined. 2 minor criteria defined as HBR. Do you think optimal duration of DAPT for HBR or LoBR? We don't know optimal duration. No previous study has evaluated the specific duration of DAPT according to bleeding risk. The current guidelines recommend stratifying stented patients according to BR. For low BR, patients can consider longer DAPT. For high BR, patients should consider short DAPT. General recommendation is 3 to 12 month DAPT for low BR, 1 to 3 month DAPT for high BR. However, we do not have evidence based on ARC-defined BR which duration would be optimal where the thrombosis bleeding risk will cross. There have been 11 studies enrolling so-called HBR patients for the last 10 years, from 14 to 24. But 4 were registries compared with historical control. 6 were RCTs, but they compared different devices under 1 month DAPT. Only 1 RCT compared different duration of DAPT, 1 versus 6 month DAPT. But all previous studies enrolled their own criteria, not ARC-defined HBR criteria. Here, gray color denotes the registry compared with historical control. Yellow 6 RCTs compared different devices under 1 month DAPT. The initial point is leaders' free trial. They developed by Freedom, tried to compare BMS under 1 month DAPT. At that time, in common sense, we thought 1 month DAPT would be enough for BMS. Thus, they tried to compare by Freedom with BMS under 1 month DAPT. And next, Zeus uses Endeavor versus BMS, Synergy versus BMS. Onyx 1, result Onyx versus BioFreedom. BioFlow DAPT, Osiro versus Endeavor. Compare Supraflex Cruise Stent versus Tansei under 1 month DAPT. Thus, most physicians misunderstand 1 month DAPT is optimal duration of HBR. It is not. They just compare different devices under fixed 1 month DAPT. The only one RCT is a master DAPT here that compared different duration of DAPT. Which duration? 1 versus 6 month DAPT in 2/3 of their cohort without anticoagulant users. 1/3 used anticoagulant, and then they compare triple, double, monotherapy, 1, 5, 6 month versus 3, 9 month. That's all. In this trial, 6 month was not good because of higher bleeding. As you know, 6 month is common sense, too long for HBR. Thus, most physicians misunderstand 1 month is the best duration of DAPT. But we had some question. How about 3 months? 3 months would be not so long, but enough to protect thrombosis. That's the reason why we start this trial. The first randomized study to stratify patients receiving PCI with DS according to the bleeding risk based on ARC definition. This is the first study to enroll HBR, defined by ARC, not so-called HBR in previous trial, and to test different durations of DAPT either in high or non-high lobial stratum. For high stratum, randomized to 1 versus 3 month DAPT, lobial stratum, 3 versus 12 month DAPT. We adopted 3 co-primary endpoints at 1 year in hierarchical order. The first, NACE. The second, thrombotic event, MACE. The third is an actional bleeding. Hypothesis is within each stratum, for the first and second component, short DAPT be non-inferior to longer DAPT. For the third endpoint, short DAPT be superior to longer DAPT. This is our hypothesis. We calculate sample size based on the assumption of NACE as 9% at 1 year, and we set margin about 1/3 of this assumption rate, 2.7%, leading to sample size 1,600. For lobial, we assume NACE at 1 year as 5%. We set margin 1/3 of it, 1.5%, leading to sample size 3,300. And then we enrolled about 5,000 patients from 50 centers and stratified them into high versus lobial, 1/3 high, 2/3 low. When you return to your cath lab, you will also find 1/3 of your patients high-BR, 2/3 low-BR. Is a universal phenomenon, at least in East Asia. High-BR stratified, randomized into 1 versus 3 month DAPT, low-BR 3 versus 12 month DAPT. Then we checked 1 year, NACE, MACE, any bleeding. Randomization is process here. Eligible patients were centrally randomized by a web-based randomization sequence, and data were collected by a web-based electronic case report form. The founders of this study had no roles. Here is the study organization. Here is actual patient flow. About 5,000 patients are stratified into high versus low BR stratum. They randomized into 1 versus 3. 3 versus 12 months. About 99% of the patients followed 1 year. The results of high BR stratum. Baseline profiles, female 1/3, 40% stable, 60% ACS, diabetes over half, CKD 1/3. These two factors are also thrombotic risk. As you can imagine, high bleeding is overlapped with high thrombotic risk. That is very important message. With this PCI, 20%, CVA, 15%. It's very high risk in general clinical features. That is feature of HBR. Main DAPT is clopidogrel DAPT in 90%. That is the current practice pattern in Korea and Japan. The results is shown here. The first component, NACE, in HBR stratum was 18% after 1 month DAPT, 14% after 3 month DAPT. Difference is about 4%. 1 month did not meet non-inferiority to 3 months. Actually, interval is above 1. 1 month was inferior to 3 months in terms of NACE. Why? It is mainly driven by difference of MACE, thrombotic event. That was about 10% after 1 month DAPT, 6% after 3 month DAPT. 4% difference, interval is above 1. Thus, 1 month DAPT was insufficient to protect HBR patients from thrombotic event, too short. How about bleeding? About 14% after 1 month DAPT, 16% after 3 month DAPT. 2% difference. Interval, cross 1. Not so different. Main difference here is BARC2 bleeding, minor bleeding. Thus, if you shorten DAPT down to 1 month in high bleeding, you can increase thrombotic event without significant reduction of major bleeding. Here is each component of 1-year outcome in HBR population treated with either 1 month versus 3 months. 1 month increase thrombotic event here by 1.7 times. Bleeding event is reduced by about 15%, but mainly due to the minor bleeding. Major bleeding, BARC3, no difference. BARC5, no difference. It increases ischemic stroke by 3 times. Thus, even you meet high bleeding risk patients, 1 month is too short to protect the patients from the thrombotic event. Master DAPT favored 1 month when it was compared with 6 months. Here is master RCT results. Bleeding is very high with 6 month DAPT, 1.5 times high, without reduction of thrombotic event, favoring 1 month DAPT. But I guess 6 month DAPT leading to very frequent bleeding, leading to discontinuation medication transiently, leading to thrombotic event. Thus, MACE is not different, I guess. The other important difference between HOSPIAR and master RCT is HBR criteria. They use their criteria, but that is different from ARC-defined HBR criteria. For example, they enrolled patients having only 1 minor criterion, such as age 75. Thus, they have higher prevalence of elderly population, atrial fibrillation, and anticoagulant user, twofold higher than our cohort. This is not representing authentic HBR. Just elderly population with frequent atrial fibrillation and anticoagulant users. Here is the major bleeding incidence among several studies. Master DAPT, 1-year major bleeding is just 2.5%, not reaching 4%, suggesting the population in master DAPT does not represent authentic HBR population, just elderly population with frequent atrial fibrillation and anticoagulant. Leaders-free, 7.2%. Our HOSPIAR, 7.4%. This is authentic HBR cohort. All other population, so-called HBR, but not authentic HBR population. Because we adopted it for the first time, our definition. Here's the criteria in our cohort. Anemia, most frequent. GFR less than 30, next. Anticoagulant user, active cancer within previous year, and thrombocytopenia, intracranial hemorrhage, spontaneous bleeding, non-deferrable major surgery, risk major surgery. Here is the percentage. Minor criteria, age, hemoglobin less, more than 11, GFR more than 30. We also did a subgroup analysis here. Risk of thrombotic event with 1 month DAPT than 3 month depth in high BR stratum was consistently higher across the subgroup. But please pay attention to this. Younger patients' risk of thrombotic event with short depth is very dramatic. So please maintain longer, at least 3-month depth for this younger HBR population. Normal renal function, also 1-month depth is very dangerous. But if you have concurrent oral anticoagulant, that is helpful to support insufficient power of short depth, thus it is okay. Risk of bleeding with 1-month depth compared with 3-month in HBL is negligible. But please pay attention to female. In female, you can get some benefit of reduction of bleeding with short depth, 1-month depth, than 3-month. Here is a result of low BR, non-HBR stratum. Female is less, stable 40, ACS 6 the same, DM is less, 1/3. CKD, previous PCI, CVA is very rare, especially benign population. Mainly used DAPT is Clopidogrel DAPT, about 75%. Here's first component NACE in low BR stratum, 3% at 3-month depth, 4.4% at 12-month depth. 3-month met non-inferiority. Actually, interval was less than 1. 3-month was better than 12-month. Thrombotic event is very similar to each other, suggests 3-month did not increase thrombotic event than 12-month in low bleeding stratum. The main difference was driven by any actionable bleeding, 7% at 3-month, 11% 12-month. Interval is less than 1, suggesting 3-month was significantly better than 12-month in low BR stratum. Here is each component. Bleeding event is reduced by 1/3, reduced mainly the mild bleeding, but BARC3 bleeding is also reduced. We did subgroup analysis. This is risk of MACE with shorter 3-month depth than longer 12-month depth in low BR stratum. No difference. MACE is not different in all across the subgroup. Risk of bleeding with 3-month depth than 12-month depth in low BR stratum is consistent in all across the subgroup. 3-month was better than 12-month in terms of risk of bleeding. The final notion of this study is the totally different clinical course between high BR versus low BR stratum. Here, major bleeding is higher, about 5 times higher in high BR than low BR, because the word means high BR. But please pay attention. Thrombotic event is also high, about 3 times. Death rate is about 10 times. Cardiac death, 7 times high. Thus, high BR stratum means not only bleeding risk, but also a general risk. Mortality risk is very high. Limitation, open label study, specific PY inhibitor during DAPT period or as a monotherapy agent after DAPT was left to doctor's discretion. That's the reason why clopidogrel was mainly used as PY inhibitor at discharge. This is because we all know key RCTs of ACS and AMI in ruling East Asians have shown clopido is superior to ticagrelor, leading to clopidogrel as the standard and most frequently used regimen, although ticagrelor is recommended for ACS in Western world. The findings may not be generalizable to all ethnic groups, but optimal duration of clopidogrel for East Asians may be applicable to ticagrelor for Westerners. Conclusion, in HBR population, 1-month DAPT was inferior to 3-month DAPT for thrombotic event at 1 year, while there was no significant difference in any actionable bleeding. In lobial stratum, 3-month DAPT reduced any actionable bleeding without increasing thrombotic event compared with 12-month DAPT. Overall, 3 months would be the optimal default duration of DAPT after PCI in general to meet the balance of thrombosis and bleeding, suggesting resurrection of concept one size fits all. Thank you very much for your attention.